talking about hypoglycemia in the sub-Saharan African region, I would basically, based on my clinical experience in Tanzania and from the region in East and Central Africa, from what I know and what I hear, I think we have got 4 problems. One is that most of our patients do not have a home blood glucose monitoring devices. So they are not able to know when they are getting hypos or when they are going into a stage of a hypo if they don't have symptoms. And for many of them, the symptoms of hypoglycemia, unless the healthcare provider has talked to them regarding what the symptoms are and has educated them about it, they would not be aware. So for example, in a hot tropical climate where the room is quite hot and somebody is sleeping, and if he sweats a lot, whether that sweating is because of hypoglycemia or that is because of the heat and the humidity, you would not know unless a partner or a wife or a husband or a spouse or somebody realizes that this gentleman has got cold sweat and is actually going into a low blood glucose. So I think the awareness, first of all, awareness among the people with diabetes is low because I do not think that they have been imparted adequate knowledge about hypoglycemia. Second thing is that with the healthcare providers themselves, usually you find in a clinic where it's a busy clinic, patients with diabetes are probably not enough time is probably spent talking about if they have hypoglycemia. So I think you've got double-edged sword here. One is the doctor or the nurse not talking to the patient that if you get a hypo, this is the symptoms you should expect and this is what you should do. And from the patient side, not realizing that at what level should your hypos be defined as hypo or unless you start getting symptoms. So I think the question here is for the region, there are 3 things. One is the healthcare providers need to know that hypoglycemia is becoming a major issue, and depending on what type of medications you are using, if it is insulin, if it is oral hypoglycemic agent, if it is a long-acting sulfonylurea, and based on the eating pattern of the client, you should be able to advise them about the hypoglycemic episodes if they get, and if they do get, what they should do. And second thing is then from the patient side, I think the nurse education or diabetes education is very important when they should realize that what the blood glucose is probably going down. But as I said, more than 90 to 95% of the patients here would not have their home blood glucose monitoring. So they're entirely dependent on the symptomatology, or they are dependent on somebody telling them that, look, you're getting low glucose or you're getting dizziness and something, you do it. So it's a question of having something and you find that your symptoms improve. If you take a bottle of Coca-Cola or Mirinda, which is immediately available, which has got 14 teaspoons of sugar in it, then you might find suddenly somebody has an image change. So I think that is where the challenge we have in the region. Regarding the published data, I personally do not think, try to look at the literature. There's very few data from South Africa probably, but real published data to say that what are the incidence and what is the prevalence of hypoglycemia, I don't think we have something very solid from the region. One of the observations which I have is that you might find that the threshold for hypoglycemia is variable in different people. So you might find somebody walking into your office with a blood glucose of 2.5 or 5, and he has got no symptoms at all. And then somebody who has got a blood glucose of 4 or 4.5, and he has got a classical symptoms of hypoglycemia. So I think that the level at which you say it is hypoglycemia, and somebody starts feeling that hypoglycemia, the levels are different depending on what group of patients you are talking about. It's going to be a long time before we start having CGMs for patients. I think it's going to be a long time before people are going to be able to afford home blood glucose monitoring with the glucometers. Of course, the penetration is improving, but I think we have still got a long way to go. I feel the issue here is if the healthcare provider spends some more time with the patient with diabetes, whether it is type 1 or type 2, looking at his eating pattern before you decide what medication and how you are going to give him the medication, that will help quite a lot to reduce the incidences of hypoglycemia. To give you a very simple example, in our setting, most of the people would leave a house at 4 or 5 in the morning and probably have a very mild snack on the road when they are coming near their office. And then they would have a very light snack in the afternoon. And then when they go back home at night, around 8 or 9 o'clock, that is when they have their main meal. Now, in this individual, if you are going to dose him with a classical saying that you need to give a higher dose in the morning, and you give him a long-acting sulfonylurea in the morning, and when he's not eating enough food, you see, he's bound to get into hypoglycemia in mid-morning or mid-afternoon. So I think that history of what is the eating pattern and what is actually happening, that helps a lot in reducing the hypoglycemic events which you see. Second thing is that when they have these incidences of hypoglycemia, the patient actually tells you that, look, I was trembling at night, or I had a lot of cold sweat and I was feeling very dizzy. So picking up those symptoms of different variations and different presentations, I think when they come to the clinic, will help you a lot to improve, reduce the incidences of hypoglycemia. And the third thing I think is that we have to be very cautious when we are dealing with older patients more than 60, 65 years of age, who has got a multi-polypharmacy because they are being treated for hypertension, for dyslipidemia, for stroke, for diabetes, and you find there's a huge interactions taking place. So I think it's a question of how much time you spend with your patient, how much time you spend giving him an education, understanding what he says. That will, I personally feel that more than 50 to 60% of the incidences can be reduced by then. Second thing is that if you have somebody who is repeatedly having it, probably borrow him a glucometer, let him go and check it at his home for about a week or so. And then once he brings the results, you can do the necessary adjustments you need. The interface we are looking at is probably a nurse or probably an expert patient, where we call as a peer educators. And we have done some pilots with the peer educators, and when they are expert patients, and when these expert patients basically talk to their colleagues, I think it makes a lot of difference and they are able to understand well. So I think it is using an interface in between and training that cadre of interface to ensure that they can spend more time with the patients. I would say over the last 3 to 4 years, there has been a change. There's been quite a significant change, because when people were not coming forward and then they were starting to have a complication, they were ending up having much more complications, which were much more debilitating and causing their daily life to be affected. So I think that awareness has definitely improved, and with the increased awareness, although there, I would say still at that time, I would say for every one diagnosed, there might be 3 out who are not diagnosed. I would say now it might be 1 to 2, probably, I think so. But definitely the awareness has improved and people coming forward has improved, definitely. According to our STEP survey, which was done in 2012, we have currently a prevalence of around 9 to 9.5% of diabetes, out of which 90 to 92% was diagnosed during the survey. This is gone up from about 2%, which was there in 1986. So we are at around 9%. Second thing, I think, is that many of these patients who come to the hospital, they come not with a diabetes as a diagnosis. They either come with either loss of vision, or they come with a renal problem, or they come with a cardiac problem, or they come with a stroke. And also, if you look at the mortality information which you get in the death certificates, you find that probably the diagnosis is cardiorespiratory arrest secondary to stroke or secondary to acute myocardial infarction, and then somebody does not write that probably diabetes is the underlying cause. So I think that prioritization is probably because of the classification or how the diagnosis is made. But increasingly, the way I've seen over the last 2 to 3 years, definitely it's becoming a priority item, in the sense that not as much as hypertension, which is more than 29%, but definitely people are more aware and more resources are going into it.